And it was quite a privilege to hear the history of your organization, and I look forward to meeting Dr. Milner sometime during the intermission to compare notes on, on the development of a research institute. You really have something to be proud of here. It's a hallmark for Canada. And I was really very pleased to see that you have a backyard in Toronto. You've embraced a Canadian presence and a recognition on it, and you're welcoming the opportunity to move into a global setting as well, which is something I'll speak about. My experience primarily over the roughly 20 years in Africa is, yes, okay. So greetings here, and as in Halifax, as in Toronto and Halifax, we have a recognition of the ancestral home in our part of the country. It's the Micmac First Nation, and we celebrate with them, and we're proud to be a partner with them in the development of our area. Dalhousie University, of course, is in Halifax. I don't think I need to show you on the map where it is, but the connection there that we've tried to enrich over the past 20 years is primarily in Eastern Africa, but now it extends to India, Indonesia, Nepal, parts of, and a good part of Canada. But I'll be focusing on the work that we've done in Eastern Africa. And on the left is a picture of the hospital and the research center where I work. So the objectives I hope we can accomplish is to help you understand what the principles for micro-research are, where the name came from, and what it is we're trying to achieve. So the first part I'll be talking about yesterday, how it came about, the rationale for it. Then I'll branch into just where we are today and speculate on some of the challenges that are going to be faced tomorrow. And I hope you'll identify opportunities that you can provide into the development of global health, particularly in the rehabilitation areas of the world. I should say, just pure coincidence, we're in the middle of a workshop, a virtual workshop. My partner in Halifax is carrying on with it today, but the virtual workshop is with in Tamil Nadu in India at a rehabilitation center. So I feel I'll pass on some of the messages that I've already felt are understood from them. So yesterday's challenges, and it was a voyage of discovery for myself and my partner, Noni MacDonald. I should say Noni is a very dynamic, brilliant speaker. She was the former dean of the Faculty of Medicine at Dalhousie, and she was actually the first female dean of medicine in Canada. But she's an astounding teacher, and it was primarily because of her that the first workshop took place. And this is a picture from the first workshop. It was in a small city in the southwest of Uganda called Mbarara. And they had invited, or they had asked the Canadian Pediatric Society to help them develop a 2-week, or help them hold a 2-week workshop to try and train clinicians how to become scientists, to embrace that transition. It's something that I think you've definitely achieved here in trying to bridge that gap, but it's something that is really was new in Africa. So we were invited there. There were 18 participants. I think most of them you can see there. And over 2 weeks, we went through what we thought would be a useful way of trying to understand how a clinician has a way of contributing to research in their community that's going to improve the health of everyone. And Noni and I were delighted with the outcome of it. I mean, the enthusiasm was just palpable. Literally, at the end of the workshop, people were jumping up and down with excitement with what they saw as the possibilities that they could have to improve the health in their community. So, well, two of the examples of topics that were developed there for doing research, one was about head injury and risks in MBRI, which were quite significant, road injury and so on. And why do some mothers seek care early in their baby's severe diarrheal illness, and why some mothers delay it until it's an unfortunate outcome for the child. So it's a picture of Noni at the top, myself, and Dr. Jerome Kabakianga. He was the head of medicine at the time in Embarara. They have a faculty of medicine there. And we met with him at the dinner at the end of the workshop. Noni and I were just excited with it and thought, well, we've just sort of opened the door for development of clinicians to become scientists here. And he sat down and told us the reality of the situation, starting with a blunt statement. Bob, Noni, you've done a terrible thing because you've opened their eyes to a possibility, and now I'm going to have to close it because we don't have the resources to support research, even the small grants we were talking about. And we don't have mentors, we don't have teachers and the like. And so I'm afraid nothing will come out of this. Well, we took that as a challenge, and it took about 2 years before we could go back, but eventually we went back with a program, and I'll describe how we came about it. We wrote an editorial in the Canadian Medical Association Journal trying to point out how important it is for us to open our doors to developing global health. We recognize that we have challenges, but our challenges are minuscule compared to the challenges that are faced in that part of the world, East Africa and many parts of the developing world. So what low-income countries, there's a research gap. And the focus of Millennium Development Goal donors, I'll tell you what MDGs were, was building buildings, big projects involving perhaps hundreds or thousands of people there, big picture ideas. And largely those things would disappear once the Western know-how would leave, when the funds ran out. That would be the end of it. It would be nothing that would build on it. And at the same time, although we can contribute largely to buildings and equipment and things, at the same time they recognize that in their communities, the new knowledge is just not being translated into improvements in the health system. The communities and so on are so different from ours, the cultural relationships and so on. So their attitude was, just quoting here, when the Western countries come and ask to participate in research, essentially what they're saying, you find patients, collect the data, and give it to us, and we'll leave you there, leave it at that. There was no opportunity to develop their own questions to their own problems that they see every day, that we, as being outsiders, have no insight into why it is. So over that 2-year gap, excuse me, we worked at finding collaborators, funds, and so on, and also a basis of how we could develop something that would meet the real needs that they have. And one of the things that we did was we canvassed them for their opinions. We had built a relationship with both senior people who were involved in research and people who might be just entering it, and we canvassed them. So 3 or 4 very important questions. Question 1, if there was $1 million for maternal child health research, how would you like it distributed? And 2/3, almost 3/4 of it was on community research and on helping to improve the health systems in the country. Next question. If there was $100,000 to help university health faculty become involved in research, how would you distribute it? And there, the vast majority of it, they identified spending it to help develop the young investigators so that they will have a future. This is interesting because the reason there's 2 percentages there, we broke it down into people who were senior researchers, institute directors, heads of faculties, that sort of thing, and people who are just entering into it. And they both agreed. We should spend our resources on the people who are just entering the field because that would be the future for their development. And next question, what are the 3 biggest challenges to building a research, developing a research health component? And they identify health researchers, the researchers who are potential researchers there, with more potential than actual researchers there, have interest and enthusiasm, but they don't have the knowledge, the skills, the equipment, and so on, and for moving ahead on that. And the final question, I think, was the one that really set the tone for where we were going to go. If there was $50,000 available to support research projects, how would you use it? And we posed it to them. One $50,000 grant with a very low acceptance rate because it would be critically reviewed. Nobody wanted that idea. A middle ground, a few people like that, but the vast majority, and it was identical if they were senior researchers or junior researchers. They said, put the money into small seed grants that will have a high acceptance rates and where you'll be able to coach and mentor and help to develop research in that way. So those were our targets. Around that time, I was reading the book about microfinance. I don't know if you're all familiar with it, but it developed in the 1970s, I think in Bangladesh, by Mohammed Yunus, and it's transformed. It's transformative, truly transformative, over 50 years, I guess you can say, about how the economy has developed in India and Bangladesh, and it's spreading over into the Eastern Africa as well, because it's created a culture of entrepreneurship among the people. The principles of it, they would train and provide small loans to people who have the potential for developing their own business. This would be, a loan would be from a bank, which is not usually accustomed to giving a small loan to a high-risk individual. But he convinced them that this was the way to go. In the local setting, they would build the capacity, whether it's having a sewing machine and starting to make clothes, or a food industry or the like. And at the end, the outcome was that they would pay back the loan. And as it's turned out, these high-risk microfinance loans the vast majority, and there's payback to them, both to the banks that made the loan, but to the communities which was enriched by this. So our model is kind of developed on that. We call it micro-research. It's small seed grants with a lot of mentoring and coaching to make sure that they're successful. Small grants that are intended for the local setting to deal with the local issues that they identified, and communicating through Skype and Zoom and the like. And the outcome, there's no payback involved. The payback, if you like, is by seeing an improvement in the health system in the local country. So around that time, actually in 2008 as well, there was a conference at a United Nations and World Health Conference in Bamako in Mali, and it invited the ministries of health and education from many of the sub-Saharan Africa countries, and asked them, how should we develop a system for health and health research? And essentially, they issued 20 or so action items. But essentially, they were saying, we want to be driving the bus. We want to determine what the needs are and what the priorities should be and develop it from there. We need your help because we need these skills that we don't have now. But we need research to inform policy and policy to inform research where the needs are. So that was certainly one of the guides that we have. And MDGs, the Millennium Development Goals, were just really starting around that time. Where the United Nations and the countries of the world got together and decided that we should focus on helping the developing world improve the health that is available, and for a healthy world, a global obligation. And low-income countries, they stated they have 25% of the global disease burden, but less than 1% of the healthcare professionals to deal with it. So there's overwhelmed with all of the needs that are there. This is a map, and you don't need to get too involved with the geography on it, but the dark areas are where the worst child mortality exists. And I'll show you how it developed afterwards. So sub-Saharan Africa has a major part of it. And how they are measuring child mortality is, of the children who are born, how many of them reach 5 years of age? And for us in Canada, it's been a long time that number is sort of one in 100, 1 in 1,000, sorry, won't meet that. You and collectively, I guess, have contributed to make that such a low figure. But the dark areas are essentially, we're about 20% of the babies who are born in those countries will not reach 5 years of age alive. Can you imagine, how that affects your culture, your attitude towards family and the like, in very remote, isolated areas? So this was, worldwide, it was 93%, 93 out of 1,000, sorry. So roughly 10% of babies won't reach, but in sub-Saharan Africa, it was double that. So this is in 2020. You might notice that in the Americas, there were considerable improvement, but virtually no improvement over that time in sub-Saharan Africa. I'll bring back something on this. So we founded MicroResearch with certain principles and pillars. we were intent to decolonize research so that research as we anticipated would become, not be confined to the normal boundaries that we envision for it, that it would be research that they embrace and they decide on, make the decisions on. And the democratization means for us that everyone has a place in the research field. Everyone has the ability to contribute to demystify the research aspect. And the pillars that we embraced were through education, support for research, volunteerism, community engagement. This is from a paper that was done quite a while ago by Kuhn, but it's kind of a universal truth. If decision makers are at the center, decision makers have restrictions on what they can do, legal, financial, and so on. But who influences those decision makers? They are the people in their immediate community who they know, they trust, who they believe have quality to provide for them, quality of knowledge, quantity, and for helping them. The blue circle on the outside are us, if you like, the come from a ways, the organization, and to penetrate through to the decision makers, there's all sorts of layers and barriers. So the principle we had from MicroResearch, we're come from a ways. We're going to visit low-income countries. We're going to try to provide the skill set so that that inner circle will be the ones who influence and help to improve the health in the country. And we're thinking of a health in a broad system, not confined to medical aspects, but health in terms of the education of the community, employment, the environment, and things like that. Certainly health, providing health and medicine and so on is a component of that, but the predictors of health are broader than that. So, MicroResearch, we wanted to address local problems, have local teams deciding on that, what the problems were and what the solutions would be to bring it about, and to have teams approach to research rather than individual components to it. So when we are holding a workshop participants are divided into groups initially, and they become teams with time. Typically, a workshop would be 20 or 30 people, diverse backgrounds, so we would have as diverse a background as possible, a few physicians, nurses, physiotherapists, psychologists, whatever can be recruited, and each team would be as diverse as we can make it, and as balanced a gender within the teams as well. Each team was assigned a coach, a local coach from their institution, from their university, someone who has more senior expertise in research. And we would conduct the workshop trying to impart what skills we have and what they would need as they, at the same time as they developed their own research idea. And at the end of 2 weeks, they would present it to their colleagues and their advisors anyway, just what they've come up with in that time. And I'll show you some of the examples of some of the research team projects and the outcomes from that. So there's 3 aspects to time sequence on this. First is what I've been primarily talking about, the teaching of research skills. So when an institute, a university hospital invites us to do a workshop, we have to be invited. We're not going to go there unless there's a willingness and that they will undertake this and they will use their resources to improve it. We have communications back. We have train the trainer sessions with people who are going to be involved in that. And when the time comes, one or two of us usually would go from where we were in Canada to Africa, to a site in Africa, gather together, meet the 20 or so people who are going to be participating in the research workshop, meet them. The first day, every day they have a homework assignment. The first day's assignment is think of yourself and think of an area that you believe would improve health to your community based on your own life's experience and the like. Everyone is to think of that that night. And the next morning to come together and tell others about your ideas in your team. Your team would be 6, 7 people, and convince them that your idea is the one that they should approach for the rest of the time on it available. They make the decision. We're not part of that decision. They base it on their knowledge and their understanding of what the needs are and what the resources are. So the workshop continues where we go through, well, how to formulate a good questions, the finer criteria for that, an introduction to qualitative methodology, quantitative methodology, sampling, community engagement, research ethics. It all goes along over the 2 weeks, how to make a PowerPoint presentation, things like that. And during that time, the other part of the workshop, they are working as their team, progressing, moving, modifying, improving their research proposal. So at the end of that, they present it to their colleagues. We give feedback about things that they should think about and to make it an improvement. And we offer an incentive. For those teams that have shown good progress, they will have a ticket, an opportunity to apply for a MicroResearch grant. Right now, the MicroResearch grant is $1,500 Canadian. It's not a huge amount, but it is a way that we can take the funds that we have available and spread them and make them as impactful as possible. So they have time, they've had feedback, they have their local coach helping them, and twice a year they have an opportunity to submit a proposal to MicroResearch. And this is where we draw on literally hundreds of people who've offered to help us. We send that proposal out. It's in a format for a regular research proposal. They have to make the justification, they have to have a budget, etc. And we send it to people who've got expertise in whatever the question is that they've had and give them feedback. We summarize the feedback, give it back to them. These are the things you have to do to bring this up to the bar of scientific merit on it. You have a chance to do that, work on it. We assign them not only their local coach, but we assign them an international coach who will meet with them by Zoom and the like. So they have time and they make those changes to it. And if it's accepted by the coaches and us, we agree, okay, you've met the scientific bar. Now you have to take this to your local ethics committee, present it to them to get ethics approval. And once they've done that, good to go. Do your research in your local community, write it up. We'll help you publish it. We'll help you write a report about it afterwards so it will have the maximum impact possible. So where are we today? This is the background, and I can tell you about a few projects. Basil, he's the one in the middle. He was that was the first team, and their question was, Why do babies in some communities get immunized and in other communities not get immunized? A very local problem, simple problem, but hard for us. We would have never thought about it, and we would have never been able to do the work to find out. When you think of local communities in Canada, it's a highway between, and you go to the town hall or whatever, and you meet people. There, the local community means that usually often there's no road. It's a little pathway through the hills to meet it. There's a cultural challenge, of course, in trying to meet the people who can give you the information. There's language. There's 30 languages in Uganda alone. There's a language issues. So they did that. And they went out, and the reason some babies were immunized and others not was not because they didn't believe it, not because they couldn't afford it, because the World Health is providing the basic immunization free, but it was because the one time every 2 years when the immunization team comes out to their village, and the central village and everybody has to come to it, was during the rainy season, and those pathways were inaccessible, and so many of the villages didn't get immunized. So a very simple solution to that, the rainy season's twice a year, do the immunization clinics when it's not the rainy season, won't cost anything, and do the immunization clinics in the cities during the rainy season. So simple, it works. There is one orthopedic, more than one, but this is a nice one to tell you about. It was by Paul Mogali, who's in Kenya, and he was a physiotherapist, and he was concerned about the problem with clubfoot management in Kenya. And there's a management strategy for it. Many of you will know a lot more than I do about it, but babies, 1 in 1,000 babies are born with clubfoot. And if it's corrected in the first years of life, that's fine. They have a productive life. If it's not corrected, they end up being a burden on their family, a beggar on the streets, which you see many of in the cities there. The corrective method involves some manipulation of the feet so that they are formed in the appropriate way. Problem was that the corrective process cost about $300 US. The family income in those parts of the world would be about $1,000 a year. So this meant that the majority of kids who had clubfoot, the parents just couldn't afford this. So their idea was to take a much cheaper version of it, that they could build and manufacture on their own for $10. Now it could be affordable. Now it could be done. And their research was to see how effective it was, whether it was accepted, whether there are side effects, and so on. They published that in a journal to tell the world, yes, the vast majority of children who went through this process had no problems with it. And within weeks of publishing it, they had inquiries from other countries about how can we make this thing. Now they have a sort of cottage industry in making these things and sending them elsewhere. So literally in a place like Kenya, thousands of children now can have a productive life eventually. This is another study. This one was led by a team by Isha, and her question was in rural Uganda, for the babies who die in the first weeks of life, why do they die? What's the cause of it? And you have to know that there were no real statistics on this in Uganda and many of the East African countries because babies in general, when you have 20% die before they're 5 years of age, parents families know that this is a risky thing. They don't know whether this child is going to live or not. So usually they would not register them until they're 6 months or 12 months old. So trying to find out how many died in the first week, well, they were never registered, they were never noted except by the families and in the village. So what Isha had to do, she went out to the rural communities. She gained the trust of the village leaders. She gained the trust of the mothers. She asked mothers who had lost a baby in the first weeks of life to come and meet with her. It was a snowball type of a strategy to get recruits. She tabulated this on something called the World Health Organization verbal autopsy. So a series of questions where you'd be able to draw some conclusions. She brought that back to her pediatrician friends. They looked at it, they analyzed it, and just over 40% of the deaths were due to sepsis related to their umbilical cord. Interesting, I would have never thought of that. Another person was doing a study, Florence, in rural Uganda, and her question was, what are the practices during pregnancy and birth in the rural communities in the outback? Again, she had to deal with getting the trust of the people in these communities. And among the 20 or so things that she noted, some were advantageous, some were neutral, some were deleterious, potentially deleterious. And one of the ones that was deleterious was the practice of applying different material to the umbilical stump as soon as the baby was born, with the belief that this would help to dry it up and help it fall off. Among the things are certainly things that are not pure or not sterile and the like. They met at a forum that we held, 2 MicroResearch projects. Aha! Okay, this is the potential cause for the deaths of many of the babies in the first week. So like, they went to the Ministry of Health, they presented it. Both of them had published their results. The Ministry of Health, you're local people. You understand our culture, our language, and the like, and you've published it in a world-recognized journal. The solution was very simple: to apply chlorhexidine, a disinfectant, on the umbilical stump as soon as possible when the babies are born. And you could lower it to virtually zero. It doesn't matter what they put on, within limits afterwards. The government ministry engaged a company in Uganda to produce these little tubes. These are put into the mama kits. The mama kit, they called it Umbagel. And the mama kits are something that mothers, when they're pregnant, purchase, and it has sort of the rudimentary things that you need when a baby is born. And so this was now being manufactured by an industry in Uganda for all of Uganda. It's spread out now. They're supplying Kenya, Tanzania, Rwanda as well. They've got a small industry there. But the important thing is, when someone else did a survey about what's causing the death of babies in the first weeks of life, it had come down from 40% to 7%. So literally thousands of babies are being saved on this by a very simple aspect. 2 research projects, each costing $1,500. The impact on that is incredible. So, okay, here are we today. Well, it's not quite up to date with India included now. We are now doing workshops in 11 countries. There are about 500 volunteers who help us to do the reviews, to become coaches and co-teachers with us. About half of them are in Africa, half in Canada. We've done, I think it's more like 75 workshops now. About 1,600 people have participated. 190 or so projects have been launched, and 48 of them have been published in recognized journal. But more importantly, probably, is that it has changed some of the standards and the practices in Africa. We've diversified. We have a diverse group. This is the breakdown of all of the people who've participated in workshops. So about a third of them are physicians, and 20% or 25% are nurses, and then a range of others. So recently, well, 2016, not that recently anyway, we did a survey of people who had graduated from these workshops and asked them, has microresearch impacted your career? 88% yes, it had. And were you still involved in research? And 85% said that they are still involved in research in other projects, not just the one that they started with. There's an educational outcome to it as well. As said, we've been doing microresearch workshops in 11 different countries, and some of them, the universities, have adopted the microresearch principles of teamwork, fundamental research knowledge, and small grants. So it's been incorporated into the educational program within those countries. So, opportunities for tomorrow, challenges and opportunities for tomorrow. Challenges, funding. Funding is a universal problem, but with COVID, with political changes in the United States and elsewhere, the World Bank is predicting that the funding for developing of research and health contributions in the developing world is going to diminish, relatively speaking. In these countries, an infrastructure for research is very rudimentary. Research ethics process is long. Budget management is haphazard. Volunteers, we need volunteers both in Canada and in Africa and other countries, Indonesia, Nepal, India, and Africa are the places we've been to. COVID-19, it's affecting budgets and so on, and the fear of pandemics and so on will affect travel. But there are opportunities. We're embraced in new funding models. We're trying to develop our own microresearch business plan so it'll be sustainable for the future. Trying to help them overcome some of the infrastructure and to recruit volunteers, because we don't decide what the research project is, they do. We don't have control over just who it is we need. And by coincidence, in Tamil Nadu, as I said, right now, there are about 30 people who are in a rehab center. And they've only gone, today's the 4th day, but here are some of the questions that the teams want to address. What are the informal support networks for mothers who have special need children? The role that a mobile van clinic will have in rural communities, improving health delivery to special needs children. The robotic hand devices, which are probably not at the same level as here, but how much can they help to improve the fine motor system? And the role of computers. How much can, in a country where the computers, internet, and so on is not as advanced, but how much can it be used in the improvement on health? So I told you about the MDGs. We're now in the SDGs, the Sustainable Development Goals. And there are 17 of them. It ranges from environment. Health is still prominent on there. Equity is still a prominent factor in that. And so we're looking at how can you try to achieve these 17 independent goals when communities exist like you see there. Small pathways between them, high fertility rates, poor housing, malaria being a common risk factor, Ebola, tuberculosis, and so on. These are environments that AIDS, they have all the time. We've also now expanded MicroResearch to Canada. We sort of a south-north development, and we'll be doing workshops in BC and Fraser Valley and Saskatchewan and Newfoundland in this year, or this coming year. And we've done quite a number of workshops in Nova Scotia with the same model being followed. We're having to adapt it to make sure the educational, what we're providing is more appropriate. But the same model, small projects, community-based people, people who are not usually engaged in research to become part of the process. Okay, I showed you this map, remember? Okay, this was in the year 1990, at the start of the concept for the Millennium Development Goals. Look at Africa, okay? There it is, 2000, and here it is at the most recent. It may not be as dramatic as you would think, but those dark, dark areas are disappearing there, which means not 20% of the babies die before they're 5, but maybe 10%, 5% are dying. A tremendous change in how the world is evolving, and we want to see it so that Africa becomes like other parts of the world. I don't, there's only 13 minutes I have. Okay.
How long is your?
3 minutes.
Perfect.
Okay, okay. Can we run that, or do I control it from here? This is this is kind of a demonstration about participants. This is a lady from Ifakara, Tanzania. We had done a workshop there. She is a librarian. And can we start it? Oh, I got to do it. Okay. Yeah. Oh wait, got to go back. Okay, try it again. Okay. This is Heka's story. I don't get the audio.
My dream was to publish an article in a renowned journal. I wondered how this dream would be achieved. Although I worked in an academic institution, at that time I was not teaching staff. I am deeply engaged in library activities of cataloging, classification, lending of books, this all desk work. I was pleasantly surprised to receive an invitation to attend the MicroResearch training. Will I be able to fit? What will I contribute to the team? I wondered. These fears nearly shattered my dream. At tea break, I met a colleague, not a faculty member, but was also invited, and this encouraged me to attend the training. A week later, I walked swiftly to the venue, and this began my journey to the world of writing papers. In that room, I joined a team of 5 people from different disciplines. It was nice to learn that as a librarian, I could support my team by accessing references and other resources during the write-up of the paper. Yet, I still felt that I was not fitting in the team. Will I really achieve my dream? This was a high mountain to climb. In 2017, my team started process of writing. How can we get this reference? One of the mates asked. This question turned this around for me. I immediately appreciated my role and took it up, challenged to support the team. I was also inspired by the team spirit from other MicroResearch sites. Our mentors and facilitators encourage us that it is possible to work in a multidisciplinary team. On a bright sun afternoon, as I scrolled through my emails, there was an alert from my team members informing me that our paper was finally accepted for publication. Wow! Is it real happening? I was very excited. My dream finally came true on 26 December 2019. I'm now an author of a paper published in a renowned journal. With MicroResearch, any professional can fit.
That's Heka's story, and she's a delightful lady. She prepared that video on her own. But it's to illustrate, part of the thing is everyone who works in a health institution can contribute to research and has a role to play. So we're incredibly privileged to have major donors, private donors, institutional donors, Academics Without Borders, our universities, Dalhousie, our hospital, the Rotary Club have been major funders, and partners in Africa participating in this from various hospitals and the like. So we've worked in 11 countries and had held more than 70 workshops, and it wouldn't be possible without the contributions, the donations, and the like. And if you're interested, okay, this is my plug for this, but if you would like to help, especially now that we're getting into a rehab center and there are going to be projects that we don't have reviewers for and the like, I hope that you'll visit our website and take part and volunteer. It would mean potentially we'll email you one day and say, would you be willing to review this particular 4-page grant? And then thereafter you get as involved as you want. You could become a coach, you could become a co-teacher. Some have traveled with us to Africa to become official teachers for it. So here are various ways you can contact us. And if you want to become part of the WhatsApp MicroResearch, there's an email there for who to contact. Questions? Thank you.
So I'm not going to take any time on thank yous. I'm just going to open it up for questions for Dr. Bortolussi.
Okay.
Stay safe, and they're coming.
Oh, okay, sorry.
I know they're coming.
We're just a shy group. Thank you for sharing your work. It's really inspiring and motivating for I think everyone in the room to hear about what you're doing. I'm curious about some of you described some you described some of your work as being virtual and and obviously lots of in-person components. Do you have some insights about sort of what do you lose or gain when you sort of do exclusively virtual interactions? And do you think you would ever move to that, or is there something about being in person that's really precious that you are?
Yeah, our virtual experience was necessitated by COVID, so we didn't have any virtual experience before 2020, and most of it has been since then. And obviously you can carry on, you can do things in spite of obstacles like that. It's much cheaper, travel is not an expense and so on. You do lose something on it. There's that personal interactions, you have the time to chat with people over tea, for them to develop a confidence in you and the like. Those are the things that are lacking. We did try to review the virtual versus the in-kind. And in terms of their perceived satisfaction, we have a follow-up questionnaire after every workshop. 95% say they would recommend it to their personal friends, and it was 95%, 93% in the two different aspects of it. But you do lose something on it. We know that. And what our goal would be when we're doing the first workshop at a site, that we would try to do that as an in-person one, and thereafter, because the local people then start to take part as teachers as well. So there is a personal interaction, even if we're 10,000 kilometers away. Yeah, thanks. Very good point, though. Yes.
Really a very exciting and intriguing program with an incredible human passion. I'm absolutely taken with this. I wondered about the initial challenge, like how did you bootstrap this thing to begin with? The way in which you initiated the program. I see that you've managed to garner terrific donor support and a broad range of supporters. But how did you kick it off? What was the chemistry? What was the action to make the thing begin to grow?
Dr. Milner, thanks. I'll just repeat it, and not everybody might have heard, but how did it get going? How did it get started? And well, both Noni and myself, we've had a long experience in teaching and in our own research. I had had a sabbatical just before, and my sabbatical was spent writing a book called Handbook for Clinician Scientists. It was a CIHR sponsored type thing, and it was intended for clinicians who wanted to become scientists in Canada. And so part of the time during that year, I spent about half of it in Africa at the Infectious Disease Institute in Kampala in Uganda. And I just explored, would this be something that would be useful in Africa? I went to quite a few places and worked in some hospitals there and met a lot of people there. Noni has a wide circle of friends, but we drew on our personal knowledge and interactions with various people. Noni is an incredible salesperson, okay, a dynamic person to bring this about. And I think you're right. You need something, and we had enough of a foothold there. And when we went back to MBRI, again, it was a huge success. The Institute of Infectious Disease in Kampala heard about it, and we started to get invited there. University of Nairobi heard about it. We've been there several times. We're now basic teachers for the KMTC, Kenyan Medical Training Center in all of Kenya. They have 60,000 trainees and the like, and they've invited us annually to go and do workshops there to try to train their leaders how to incorporate the MicroResearch system into their educational program. So it didn't start with 11 countries. It started with one, and it started with one center, and it grew from there. Yeah, you had to be, I remember telling Noni, I just finished this book by Mohammed Unis, and he was telling me that, in the book, how microfinance got started, and it took 20 years for it really to catch on, but it's been successful. And she looked at me and said, Bob, we don't have 20 years. Okay. So, yeah, thank you.
Lovely talk. You spoke about some of the challenges of working with so many different languages for establishing this program, and I'm so fascinated by the strategies that you developed, because it's something that we are trying to do here and something that we need to do better here for our research as well. So do you have anything that you could speak to, or any strategies that you've developed for that?
Well, the presentations are done in English, and that's for most of East Africa, India, Indonesia. The like English is the second or third language. Actually, in Uganda, they'll learn their local language, then they'll learn Luganda or Swahili, and then they'll learn English. But English is our basic thing. In some, like in Tanzania, we would give the presentation, and then a local person who's fluent in Swahili would translate it for the essential parts. So they understood it. They didn't get the nuances on many things. So things like the homework assignment, it's in both languages. The objectives, we put that in both languages and the like. We've been invited to go to French countries. I can speak French fairly well. Noni can speak it fairly well, but not enough to give lectures. So we've restricted ourselves to English-speaking countries. And I'm glad, I know you don't have it here anymore, but I noticed all of the welcomes that you had. Karibu, it's Swahili for welcome. Okay. Thank you.
Yes.
Yeah.
Thank you very much for being with us and sharing. It's an incredible organization. I'm really interested in the impact you've been able to make with such small grants. I think a lot of us think of much bigger numbers for research grants. I'm curious how that money is used. Is it time for them to offset on research? Is it materials?
No, well, it's for materials and for purchased items and so on. The expectation is that they're volunteering, they're using their off time to do it. And how do we get by? There is one full-time person who works for MicroResearch. Everybody, myself, Noni, and so on, it's entirely voluntary and the like. So you can get by on a pretty meager budget, especially since we had one of our supporters was Academics Without Borders, sort of Médecins Sans Frontières, but it's designed for people like us who are academics, who are willing to go to a developing world country and to impart knowledge and show for it. Yes, yeah.
The passion and just the way you're speaking and the way you have this impact, obviously what you've done with your organization, it has a magnetism. And even though I'm here really as a parent, right now I'm supporting a kid in the hospital, it's a complete fluke that I'm even here. In my former work, I worked with kids with needs, so I was like, oh, this is interesting, let me come. Everything kind of flatlined in Ontario for kids with needs over COVID. And I'm in sports, and people are having a hard time getting back into it because of the doors are closed.
Yeah.
And so it's really been a really difficult relaunch. But because of COVID, I think we've all developed a little bit of resiliency that we would never have had before.
Right.
And we're able to do things we couldn't do before. Like before, if someone said, oh, we'll have a Zoom meeting, I was like, no, we're not having a Zoom meeting. But because of COVID, we now can do things we couldn't do before. But I think the love of and the generosity of your message is like a magnet, and it makes people want to come to you. And I'm going to volunteer. And the fact that you're not paying is why you have good people, because you're bringing the people who want to do it because it has to be done.
Yeah.
If you put a price tag on it, it's for this amount of money, it wouldn't be the same.
Yeah, thank you. Yeah, it's really built on volunteerism, both. And when I was saying there are 500 people who've signed up to help out, probably more than half of them are from Africa. And they see the need, they're dealing with it every day. And how my passion came about was from my own experience prior to MicroResearch, working in some of the hospitals there and seeing the conditions. I was just not prepared for it. As a pediatrician, trained at sick kids and working in a pediatric hospital, it's a world different from what you'll experience in a place like Uganda. Yeah, thanks.
So I may have to cut the questions for now.
Okay, thank you.
Dr. Bortolussi, thank you so very much.